This lecture is the second of two lectures for Module 4, where we are covering culture, health, and mental health. And in this lecture, the focus is on mental health. Studying mental health involves some terms that are used somewhat interchangeably. Perhaps you've taken a class in abnormal psychology, and that's a course that we have here in our psychology program, and studied about the various psychological disorders. And so the term psychological disorders, psychopathology, and abnormal psychology are often used interchangeably to refer to the behavioral, cognitive, and emotional aspects of functioning. We sometimes use the 3Ds to define what might be a psychological disorder or a mental health abnormality. Those 3Ds are dysfunction, distress, and deviance. But they're not perfect. This is a bit of a more elaborate way of defining psychopathology and outlines 5 different ways that people might define what is abnormal. So for example, sometimes it might be about whether someone scored particularly high on a particular test. So we have tests of depression, for example, where people answer a series of questions, and if they receive a particularly high score, we could label them as depressed. It's useful for determining prevalence and incidence rates. We can also define what is abnormal by looking at what is different from the norms of society. Those who disobey the societal norms might be labeled as psychopathological, and of course this could also involve the situational context. So a great example is presented here, right? Is it normal to walk around naked with strangers? In many instances it is not, but in a particular situation, like maybe in a locker room, then maybe that is okay. The fourth column here is cultural relativity. You can see that is defined as judgments are made relative to the value of one's culture, bringing our own cultural lens to looking at what's normal or what is not normal. So the view then is that culture and psychopathology are intertwined, and disorders can be understood only in the cultural framework within which they occur. The final column refers to subjective discomfort. We have our own feelings about whether things are not okay or not, so I can certainly make some judgments on my own about whether I'm feeling anxious or depressed or under distress. So defining what is abnormal may use a statistical approach, may use some alternative approaches, but all of these are used at one point or another. We also have these classification systems used for diagnostics. You might have heard of the DSM, which stands for the Diagnostic and Statistical Manual of Mental Disorders. This is published by the American Psychiatric Association, and it involves assessing psychological disorders by identifying symptoms and then looking them up in the book. There's another similar classification. The ICD, or the International Classification of Diseases, is also used more outside of it, more in Asia. They use that a lot. They use that a lot in Europe. And it differs in that the DSM focuses on mental disorders. The ICD includes not only mental disorders, but also physical disorders and other sort of physiological problems. There's also a Chinese classification of mental disorders, the CCMD. But regardless, the DSM, you can see here, the picture here is the DSM-5. The DSM has gone through many different editions. This is the 5th edition that was published just about 3 or 4 years ago now, and that's the most up-to-date edition. And things have changed quite a bit over the years in what we find in the DSM and how things were presented in there. Of course, that is how we sort of define and diagnose things. But historically, there have been much broader conceptions of the causes and root behind mental illnesses. So some historical explanations of mental illness include the supernatural, meaning theories that attribute mental illness to maybe possession by evil or demonic spirits, or maybe it's the displeasure of the gods, or eclipses, or planetary gravitation, curses, sin, and the like. And somatogenic theories identify disturbances in physical functioning resulting from either illness, genetic inheritance, or brain damage or imbalance. So soma, when you see that word, refers to body. So they're physically based theories behind mental illness. And then psychogenic theories focus on traumatic or stressful experiences. So those maladaptive associations and beliefs and cognitions and distorted perceptions that we might develop from traumatic and stressful experiences. But remember, we talked about focusing on the biopsychosocial model, and we don't maybe all believe in supernatural events, but what you're seeing in the top right picture is something called trepanning, where they would actually drill a hole in someone's head to let out the demons and the evil spirits. And although we don't tend to believe that that is the root cause of mental illness today, we still might see some beliefs related to that around the world. So culture-bound disorders is quite a bit of what we are talking about in this lecture. And these are specific disorders to a culture that are recognized within a particular culture. The culture-bound syndrome was included in the DSM-4, and there was a list, and that was in 1994. And so this is a list include from that. It's also within the ICD-10. The framework for culture-specific disorders are characterized by a categorization as a disease in the culture. And so there's a widespread familiarity in that particular culture. There would also be a lack of familiarity or a misunderstanding of the condition to people in other cultures, and no objectively demonstrable biochemical or tissue abnormalities. And the condition is usually recognized and treated by a folk medicine of the culture. So that's a kind of an idea of what we're talking about when we're talking about these culture-specific or culture-bound disorders. The idea of culture-bound disorders, that terminology, was released, and instead we use some related terms today. And these are all falling within these idea of the cultural concepts of distress, the ideas that we have behind distress. So we can talk about three of these. The bottom would be the cultural explanations of distress. Right, what our belief is the cause behind why someone's feeling a particular way or having particular symptoms. The top one, the cultural syndromes of distress, are the patterns of symptoms that cluster together. And then the cultural idioms of distress, defined in the middle here, is the way that we communicate or express our distressing thoughts, beliefs, and emotions. So these three together make up cultural concepts of distress. So we'll talk about idioms first, but just as a reminder, an idiom is simply a group of words with a certain use or idea, sort of like a commonly used expression. Example idioms are raining cats and dogs, or biting off more than you can chew. And you might know how foreigners might not understand these idioms easily. I have a great example of when I was trying to translate a test in Cambodia, early days when I was working there. And one of the questions asked about if you were standing in someone else's shoes. And my translators were utterly confused about why I would be asking any question about someone standing in someone's shoes, because they don't use that to have a meaning about feeling empathy like we do. And so it was just very confusing. So you can imagine that there's specific cultural idioms that might be native to a particular culture. So let me give you one of my favorite examples. What you're seeing here is actually a 19th version of Fusi's The Nightmare. Um, and this piece of art is representing the following. Have you ever felt like you are haunted when you are half asleep and cannot move? About eight, somewhere between 8% and 50% of all people experience what we term sleep paralysis at some point in their life. And about 5% of people have regular episodes of sleep paralysis. That is, when we're asleep and we're dreaming, our body has a natural, wonderful mechanism that almost paralyzes us, so we're not up running around and such. However, if we do sort of wake up with this sleep paralysis, for many individuals, it feels like there's somebody sitting on your chest. And so sleep paralysis is actually a relatively new term that describes what for hundreds of years many people believe to be either a visitation by an evil creature which attacks its victims as they sleep, or maybe a demon sitting on one's chest, or it feels like you are haunted when you are asleep and cannot move. There's a term in New Zealand called the old hag for this, and in Cambodia, there is a term which translates to ghost pushes you down. So any Cambodian would understand this term, ghost pushes you down, and understand this as that. But it's not an idiom that we use in the US very much. Another idiom that's used in Cambodia a lot that might make a lot of sense to you as well is something kat karun. Kat karun in Cambodian is the idea that one might overheat the brain to the point of permanent memory loss or damage, or might put the person in a weak or agitated state because of repeatedly thinking about something typically upsetting or depressing or traumatic. So it's loosely termed thinking too much. And likewise, we find similar terms in Zimbabwe, and anxious or depressed Haitians may use a term, I'm not sure if I can pronounce it well, it's reflexichi twop, I think, but it's also translated as thinking too much. So another idiom of distress that we see in certain cultures, referring to that rumination and thinking that can't be stopped. And here you're seeing a picture at the top right of a Cambodian survivor standing in front of the photograph of a prisoner at a former Khmer Rouge prison. And I'm not sure if you're familiar with the history of Cambodia, but in 1975, a radical communist group called the Khmer Rouge took control of the country, and over the next 4 years were responsible for one of the most brutal genocides in recent history, where about 2 million Cambodians died while they were forced to work in the fields, or whether they starved, were tortured, or directly terminated or exterminated because the professional classes and the educated folks were targeted. And so that time in history, which is not that long ago, was a very traumatic time where the entire country experienced this trauma, or perhaps were able to flee. And it's why we find some refugee populations in Cambodia that came over here in the late 70s and early 80s. So the idea of broken courage is another term. Bak sabat is a familiar phrase to Cambodians that loosely means broken courage. Recently, there was even a movie made called Broken Courage about one of the Khmer Rouge child soldiers who was part of the killing and the war and the trauma, and also a victim of the landmine accident and how he tries to rebuild his life. But Dr. Chim Sotira is a friend of mine in Cambodia who has written quite a bit about Bak sabat and has brought this idiom of distress to wider understanding. Um, likewise, similarly, Cambodian Khmer language sort of doesn't have a direct translation for depression. They may say Teliat Dokit, which literally means the water in my heart has fallen. So these are um, great examples of just idioms of distress. This is a clip that is also in the module, so I'll let you watch this on your own, but you can hear Dr. Satira talking about Baksapat directly. Um, and another, following our understanding of Cambodia with my experiences, are Kashal attacks. Kashal is a wind-like substance in the body. So the idea is that there's this wind-like substance in the body, and so when um, when someone feels like they're having a Kashal attack, Cambodians who suffer from anxiety disorders often experience sort of a quick onset of heart palpitations, blurry vision, and shortness of breath. It's like panic attacks. And Kashal attacks can happen without warnings. And according to Devin Hinton and others who research these idioms, this is thought to indicate that there's a surge of blood in their limbs and in their body, and sometimes people feel like they could actually die from this. So when working with individuals in the country of Cambodia, or with Cambodian refugee populations here in the USA, it's important to understand that they might speak of um, some of their symptoms that we might understand as anxiety related or trauma related, but talk about these more somatized, body related things like broken courage and Kashal attacks and ghost pushes you down. And our research finds that these descriptors coincide with descriptions of anxiety and PTSD and others. Um, I also found this cute little chart. This is a KashalAttack.com that Devin Hinton created for us, and you can look that up and learn a little bit more about that. But you can also, I've also added one or two of our research papers that talk a little bit about the largest mental health survey that was ever done in Cambodia, and making sure that we gathered some data that include reaching into these idioms of distress and not just asking people about, say, their anxiety when maybe that doesn't really translate directly as it does. So these are some hopeful examples of idioms of distress that are useful for you. Coming back to sort of the idea of culture-bound syndromes, this is like a pattern of symptoms that are present in a certain culture. So not just an idiom, but a pattern of symptoms. And according to the American Family Physicians Journal, culture-bound syndromes include a broad array of psychological, somatic, and behavioral symptoms that present in certain cultural contexts and are readily recognized as illness behavior by most participants in that culture. Again, sometimes it's termed folk illness, sometimes culture-specific syndrome. So let's look at a couple of examples. DOT is a syndrome that is characterized by feelings of weakness of body and mind and attributed to the loss of semen through night falls and masturbation. And this leads to a significant distress in the individual, a loss of datu, which is the vital fluid, and overheat, and general concerns about the loss of genital secretions reflect sort of wider issues of social stress. So this is seen most frequently among South Asian males, and it involves a belief that they are losing semen. And this makes them anxious because semen is considered a source of vitality. So the belief is that excessive loss results in serious illness. So the syndrome then becomes associated with this crippling feeling of guilt and anxieties about maybe indulging in disapproved sexual acts. The DOT syndrome tends to be meaningless in the context of the United States and other places where there are not cultural beliefs about the vitality that sperm endows, and or about the consequences of loss of sperm. So in other words, being susceptible to DOT requires the relevant beliefs that relate to semen, sexual activity, morality, health, and such. Hikikomori is another culture-bound syndrome that I've been aware of for quite some time because of my 5 years living in Japan. And it's a Japanese word referring to social withdrawal. Hikikomori loosely translates as pull inward, to pull inward, and refers to that social withdrawal, characterized by living in an asocial state, that is, with no intimate relationships with everybody, with anyone else outside at least the immediate family. And this usually is defined by occurring for at least 6 months. So that might include not participating in school or a job during that time. Typically, hikikomori first appears during junior high school or high school when sufferers end up spending time in their room reading books, watching TV, playing games. They drop out from their social world, maybe even barricading themselves in their room, and sometimes even for years. Researchers have estimated that 1% of Japanese may suffer from this condition, and it does not conform to any other specific set of symptoms in the DSM-5, despite it being very related to social phobias. And today, we also know that significant numbers of people with similar symptoms are labeled in South Korea and Taiwan, and now there's even cases with parallels to hikikomori in Western countries. However, hikikomori appears to be a largely unique syndrome in Japan in terms of its presentation and its prevalence. And you can find quite a few video clips in our module as well as online to learn more about hikikomori, but it's not an insignificant problem. If you estimate 1% of the population, there's over 123 million people in Japan, so we're talking about well over 1 million people suffering from hikikomori. Taijin kyofusho is also a Japanese term, and this is something that people say is a very Japanese social anxiety. It's actually a specific social phobia, and this social phobia relates to one's body. So it's translated more to a fear of interpersonal relations, but it's all about the fear that one's body is embarrassing to other people, or in other words, displeasing to other people, like almost like you smell or you're ugly or those kinds of things, so that it's a specific type of social phobia. So it's another culture-bound syndrome that tends to be related to Japanese. Here's another culture-bound syndrome, and it's culture-bound because it has been reported as a rare related psychiatric syndrome in Chinese populations and in Sri Lanka. But phrygophobia, as you might see from the sound of it, is the fear or extreme dislike of cold, ice, freezing things, or being cold. So it could be present sometimes as an extreme fear of catching cold, becoming cold, or of cold things. And that is also said to be a culture-bound syndrome, seen very rarely in both Sri Lanka and in China. Perhaps you've heard of the evil eye. The evil eye syndrome is associated with Jainism, Islam, and Christianity, and tends to be mostly focused from the Middle East countries. And there's many variations on the general theme, but it's all related to being cursed. So what happens is there's many symptoms that are possible when one is cursed with the evil eye, including a loss of appetite, maybe fever, maybe vomiting, depression, but it does relate to a belief that other individuals can cause harm by looking at you in a certain way. These amulets that you see here and the talismans help protect one from being cursed or to ward off the evil eye. And there's many different culture-bound syndromes, as well as many different idioms of distress. But the last I will talk about in this lecture is susto. And you can see that I put the title, is it a culture-bound syndrome or is it an idiom of distress? But susto is an illness attributed to some frightening event. And the idea is that that frightening event causes the soul to leave the body, and it's leading to symptoms of unhappiness and to sickness. But cysto also refers to just a set of symptoms like loss of energy, insomnia, loss of appetite, and depression. And it may be a lot like PTSD, right? That idea that, right, after trauma, right, we have a set of symptoms. So it's maybe related to some other culture-bound syndromes like Gris-Signy that's found in Nicaragua that mainly affects girls. But there's many different culture-bound syndromes, and sometimes it's hard to kind of differentiate whether it's actually a syndrome or an idiom of distress. So many different culture-bound syndromes to explore, but only so much time in this lecture. So I urge you to spend some time on your own looking at some of the other fascinating culture-bound syndromes and idioms of distress that are out there. But when it comes to sort of assessing disorders, right, we have to think about the questionnaires and the standardized tasks that we use, and they need to be reliable and also valid, right? So we have to be careful about bringing our own cultural bias and our own experiential lenses to decision making or diagnoses. Our education, our experience, our knowledge, and even our profession may be actively limiting how we might approach the problem if we bring our own sort of ways of assessing disorders. So one example of a disorder that is used globally is the child behavior checklist. It's used in diverse cultures to assess problems in children and adolescents. And it's helpful because it just lists a whole bunch of different behaviors, and the parent or teacher or both will just check off the items because it's hard to get, children to tell you about maybe their distress. So that's one example. Some other assessment is perhaps one of the most widely used is the MMPI, the Minnesota Multiphasic Personality Disorder, Inventory, excuse me, MMPI, the Minnesota Multiphasic Personality Inventory, which is a very reliable form of assessment that's been used and translated in many places, but then there's, of course, similar tests that are more cultural specific, like the CPAI in China uses indigenous concepts from Chinese culture. And likewise, in Cambodia, we've added the Cambodian symptom checklist to help to understand clinical states and psychopathology in Cambodia. As I mentioned, we have to really be careful about bringing our cultural biases when we're diagnosing or even helping people with their trauma. And so, given the differences in prevalence rates and culturally specific presentations of mental disorders, right, we want to match the treatment to the culture. That would be very important. And one might ask if when we're training in therapy, if you go on to serve in the helping professions, it'll be important to explore the concepts of over-pathologizing or under-pathologizing. Over-pathologizing, of course, is considering a behavior as pathological when maybe that behavior is normal in that particular culture. And on the other hand, we might under-pathologize, right? We might see a behavior as cultural, but maybe it does reflect an abnormal psychological response. So, for example, I might explain a flat affect, that is, someone who's not demonstrating much emotion, as culturally based, because as we've talked about cultural display rules, you know that in some places people are less likely to sort of overtly show their emotions, but perhaps that flat affect might be really a sign of some underlying pathology. So we have to consider whether Western mental health treatments worldwide have done more harm than good. In other words, have we been over-pathologizing? And some interesting suggestions around that, right? Anorexia as a term or as even a defined diagnosis didn't even exist in that form in Hong Kong until recently. Post-traumatic stress disorder was not a problem in Sri Lanka after the 2004 tsunami until Western aid workers insisted that they must be suffering from it. So we really do have to be cautious about how we apply our psychological concepts created by and tested on Westerners to people of other cultures and backgrounds. And we can easily refuse to accept what we see as unusual behavior as normal, or incorrectly see a symptom as an indicator of mental illness. So the chapter of your textbook, section 3, talks about cross-cultural research on psychological disorders. And there's many interesting things described that look at cultural differences or universality in many different psychological disorders like schizophrenia, depression, anxiety, ADHD, and suicide. So I urge you to read that on your own because it's fascinating stuff. But I mean, even in suicide rates and motives, there are cultural differences in suicide rates, and the motivations for suicide vary quite a bit as well. So in the West, the motivations for suicide are often linked to substance abuse or to depression. Yet in Japan, they're often linked to accepting responsibility and or preserving honor. So these differences can be dramatic in how we might work with individuals or understand their pathologies. A short summary. Universal aspects of symptoms and disease expression certainly exist for depression, schizophrenia, and ADHD, but we also find that psychopathologies are influenced by culture in terms of how they're manifested and what the meaning of the disorder is to individuals, and somewhat related to stigma. So psychopathology often includes both universal and culturally specific components. Section 12.5 looks at mental health and ethnic minorities, migrants, and refugees, and there's some really interesting discussions in there. So I'll let you read that, but keep in mind as you read that the contextual factors often are quite important. And this brings us back mostly to the American focus. But poverty, discrimination, and stress associated with being in a new country play a large role in mental disorders. But the good news is that we can often counteract that with strong social networks and family ties. Some final conclusions are that psychiatric diagnosis, how we classify psychiatric pathology, and measure abnormality are very complex and difficult issues, and they must contain both etic and emic or etic and emic elements. So we need to contain both universal, that etic, and culturally specific emic elements. Where to draw the line and how to measure psychological traits within a fluid, dynamic, and ever-changing system is a challenge. But therefore we must be cautious when applying our psychological doctrine created by and tested on Westerners to people from other cultures and backgrounds. And that brings us back to being careful about over-pathologizing. Just because we learn about mental disorders and can see signs doesn't mean they are disorders or of a similar nature in different settings. Sometimes it's hard to know when a set of behaviors warrants the label as a disorder. So I actually have two quotes that I want to end with. The first is from a favorite person of mine, Dick Van Dyke, who is 97 years of age today. And he has this wonderful quote: "I seldom get down or depressed. I don't want to waste a minute when I could be enjoying life." And he's someone who has just brought great joy to many people's lives. But bringing us back more to culture would be this quote from William Osler, a Canadian physician, who says, "It is much more important to know what sort of a patient has a disease than what sort of disease a patient has." I'll leave you with that. Thank you for listening and joining me for this second of 2 lectures for Module 4 in Cultural Psychology class.